This is one presentation which I delivered in one of the pediatric CMEs in 2016, and I have tweaked it a little bit because it will not only apply to pediatric cataract patients but also to pediatric diseases as such. And so there are two corrections which I have done. One is that pediatric cataract diseases has been cataract word has been struck off, and now we have pediatric eye diseases. And second modification, which is just to highlight the intention of presentation, is instead of patient we are educating the parents, which is so very important in pediatric eye diseases. So let's go and have dealing this counseling part in a more scientific and psychological way. So why is this so important? Because this way we are adding the human touch, and it is the most important aspect of the management, because an unsatisfied and unanswered parents mean no patient, no surgery, and no further workup which is required for all these situations. These patients who are having eye disease and diseases in childhood have to undergo a long and continuous follow-up. So there has to be a good rapport between the parent and the doctor, and if the counseling is done nicely, so this ensures a long and regular follow-up, and also the care and the level of care which is required is delivered. Again, why it is important? There are few medical legal issues. The parents are the legal guardians of the child, and they are supposed to take the decisions on behalf of the child. So consent, expenses, and post-operative care, these are all important issues which these are to be fulfilled by the parents. The parents are the caretaker of the patient, and they take decision on behalf of the patient, and they will come up for the follow-up. The child is totally dependent on the parents for all the mentioned issues. Continuing on, why is it important? Heritable and congenital conditions cause cataract and maybe some few other eye diseases in children. So genetic counseling is must, and screening of the siblings is also required so as to detect the disease in an early phase. And this is so very important for retinoblastoma. Understanding metabolic diseases, systemic syndromes, and their management is all part of the parent counseling so that they understand the disease and the risk involved in the siblings and also in the forthcoming children. Now let's come and talk something about the psyche of the parents at the time of diagnosis. So this is a very famous hypothesis by Kluber-Ross, who hypothesized that whenever there's a undesirable accident or loss of life of one of the close person in your life, any normal person will undergo 4 phases. And this has been extrapolated that any unwanted accident will also excite the similar response. So the chronology is such that first there is denial with shock, so that the person who listens to the diagnosis is not ready to accept the diagnosis. And the response is that they seek second opinion and they criticize the doctor who has given that particular unpleasant diagnosis. And second is the phase of resentment. The person tries to find out that why has this happened and who may be the person who is responsible for such a ugly incident. So they seek reasons for the disease or event, and in this process they may find someone to blame. Either each other, that is the parents may blame each other, or the concerned doctor who might have given some kind of treatment in one or the other form. Then comes the depression. The person feels sad, rejected, and has a question in the mind, why me? Why is it me who has been affected by this disease in my child? And then is the final acceptance phase where the person finally lands and seeks treatment and prepares for the upcoming challenges and actively talks about the problems and participates in discussion so as to find a best possible outcome. And this is where we want our patients and the parents to land so that the further treatment plan can be executed. Now, dealing with each phase, if we look at the each phase and the parent or the guardians of the children who are affected with these diseases may be in particular phase when they come to us. So each phase we should handle them little different, and this is what I'll be discussing in this part. So a person who is in denial mode, he needs assurance and confirmation of the diagnosis. So take time to examine, even if the leukocoria is so very apparent that this is retinoblastoma, but still give it some time so that it is apparent that you have done a very careful examination before reaching to that diagnosis. And don't make it a breaking news kind of event so as to glorify your clinical skills. And put up your diagnosis as a possible diagnosis and offer investigations which will confirm this so that there is a definite latent time and a buffer time so that the parents are able to assimilate the diagnosis better. A person who comes in a resentment phase is usually having some kind of irritation and agitation, and so we should be more polite, listen to their arguments, explain the disease and possible causes, and it may be a good idea that not to press too hard on heritability of the disease because it may cause bitterness among the spouses. Then comes a phase where the person is in depression. These parents need to be encouraged to ask questions so that they simply slide into the next phase, that is acceptance. Tell them the positive signs, tell them the good part of the outcome, and they should also participate with other parents who have had a child with similar disease who has recovered now. And there are forums and website on this era of internet where there are all possible discussion forums where these discussions can be done and the doubts can be removed. There are few issues or the question in the mind of a parent. So they may be that, is my child blind? Because in pre-verbal children it is very difficult to judge whether the vision is there or not. So specifically for cataract the answer can be yes and no. Yes, why? Because yes, the vision is not normal, and no, because this will recover. So will my child will be able to see normally? Most likely, but it depends on number of conditions. Any procedure which is to be done in these children is to be done under general anesthesia. So one should be prepared to counsel the parents about the pros and cons of general anesthesia and the safety associated with other associated systemic disorders. If the parent is concerned about the life of the IOL, because in an old person where the life expectancy is not as prolonged compared to a child, there is a concern about the life of the lens. So although we all know that the IOL will last for the lifetime, but still there may be a need to change the lens because the refractive power of the growing eye will change. There is frequently a question that is there something else apart from the surgical option, and for various diseases which we encounter in children, it's very important to institute early possible treatment. So any such myth should be cleared away as early as possible so the disease is managed well in time before amblyopia sets in, and this is so very important for cataracts. So time of the surgery is again very important, and the options available should be clearly discussed, and any option which is not a standard protocol should be discouraged and clearly informed that this is not one of the treatment or a successful option. Consent is one of the very important part in this situation, and there are a few nuances because the consent is not being taken by the uh, uh, given by the patient himself, but it is rather a consent which is taken from the parents. And these are the issues which should be included. Consent for general anesthesia. Parents have to understand that visual gain is not like adults where you have done a surgery for refraction and there's immediate visual gain. Pre-op visual assessment is not very precise in non-verbal children, and rather children it may be difficult to judge the vision very precisely. Now whether to implant an IOL or not and the advantages disadvantages should be discussed so that a best decision can be taken. In spite of IOL implantation, cataract patients may need glasses, especially children, as the age progresses and the refraction changes. And in cases of diseases where the outcome is not predictable in a sense that there may be comorbidities like traumatic cataracts can have various other issues like vitreous hemorrhage, there can be detachment, there can be optic nerve trauma, and there can be glaucoma in coming future. All these things should be included in the consent. A B scan should be done in situation where fundus media is not clear for the fundus view, and for diseases like retinoblastoma, neuroimaging is must so that one is sure about the spread of the disease. An important part of this counseling is the post-operative care. So the instruction should be explained and also given in writing, and there is a simple dictum for that. Whatever you tell the patient, you write it, and whatever you write, you tell the patient or the parent. The treatment in a child has been initiated and it is not the final destination. So it's an ongoing journey. Ocular hygiene and medications are to be instituted properly, and this has to be explained and given in writing to the parents. Schedule for examination are more frequent, longer, and there have to be threshold signs, symptoms explained so that the parents can visit the doctor early if there are any issues. Glasses are to be used as early as possible and as regularly as possible. The number of the prescription glasses, the refraction will change, so regular visits are required. A very small child who can understand and play game has to be taught a E or a C chart so that the child can give a visual assessment on the standard Snellen's chart. And the sound eye has to be occluded at times to treat amblyopia in unilateral cataracts and diseases where there has been occlusion or deprivation of the light to one of the eye. So this is all I can think of the parent counseling when you are dealing with that pediatric eye disease. Thank you.